Hi all, good morning. So I'm Martina Fonseca and I'm an analyst at NHS England. And I'm here to talk today about a discrete event simulation model to try and understand the relation between response times for ambulances and handover delays and the impacts, how it can assess maybe the impact of some improvement strategies. So for context, in the past couple of years, we've seen ambulance performance deteriorating considerably. So if we consider the time that it takes from more or less the call is made to arriving at scene, for instance, for emergency calls, that includes stroke, that should be on average around 18 minutes, according to national target, but that has been increasing quite substantially, especially during winter periods. The same with handover delays. So that's a period when you arrive at hospital to which clinical handover happens. Ideally, that will happen within 15 minutes. You have a lot of situations, so in yellow and red, where that's gone over 30 or 60. So this is from 2 winters back, but actually last winter as well, we saw around 4,000 hours on average being lost a day to handover delays. So the urgent and emergency care recovery plan has been published early in the year, namely the commitment around reducing response times, and it suggests mainly doing so by boosting capacity in the ambulance fleet. So the exam question for us so early in the year was really, in this context, can we better understand the relation between response time, so from category 2, but also for category 1, so those are the life-threatening, including, for instance, cardiac arrest, the handover delays at hospital and the availability of these vehicles, and then what is the impact if we do some other things like increasing vehicle hours, changing the model of care. So, for instance, not all of the incidents include conveyance to hospital. Some are so named see and treat, so you treat them at scene, and so forth. Now, obviously, this was seen more as a potential augmented decision aid. So there's other considerations like the clinical outcomes, or you might think in terms of obviously the staff well-being, and so and other econometric models and local intelligence. But we thought that this could help with some of those what-if scenarios in a more prescriptive way. So why isn't this so direct, for instance, the relation between handover delays and response times? So if we consider that patient at the scene, so the ability to get to them depends on available vehicles, so those on duty, but also the workforce that can crew them, and also, I guess, the instantaneous availability, because they might be on duty, but often they are attending to jobs. So the job can, that includes the full journey when they're with a patient and up to the point of clearing the vehicle for the next one. And that in turn is a lot dependent on, are those ambulances queuing at the emergency department? Now, some or a lot might not be in the direct gift of that service, because if there's issues with handover and further downstream, there might be limits to what can happen here. But I guess then the question also becomes, well, to which point is it helpful to increase vehicles if we have that kind of bottleneck downstream? So that's where we thought, well, discrete event simulation can help you understand those nonlinear relationships. It can also make you look at percentiles. So what happens at the 90th, the 10% patients that wait longest. And you can also look at different scheduling and so forth. So this is from an operational perspective. So as we said, there are other considerations then in this. The scope is the ambulance setting. We also restricted it more to face-to-face. So there is a portion of incidents that goes through hear and treat. So that's where they get from the 999 call, and they eventually end up at a clinical assessment, but an ambulance isn't dispatched. And also to say that even though the ambulance was a setting, we did create a stylistic emergency department, so to say, because we did want to convey to some extent that the ability to hand over does depend on some resource-constrained capacity downstream that has a certain number of capacity and the given process time, so time spent in A&E. And we use an open source package for discrete event, in this case in R. So what do we mean by representing it as a queue? So what we have is we have incoming demands. So in terms of incidents, what then happens is this will start the clock. There will be some time for allocation of a vehicle. Then there'll be a period of travel to scene that will stop the clock. There's time spent on the scene, and then travel to hospital. Then you have that period of handover of the patient, and then a time when the ambulance is trying to clear the vehicle. And all that from mobilization to clearance is the ambulance job cycle time. Now you can see that there's at least two places where you have these natural formulations of queues. So you have one for those on-duty ambulances. So they'll queue the calls or the incidents of the different categories. And those will be allocated based on the priority of those, so those categories. And then also then here for the ambulances queuing for the emergency departments. And there's also so-called competitive element, because there's also walk-ins that are about 3/4 typically of those entering the emergency department. So what is in our model the input? So the inputs is the demand, so also by category and care model, as in do they need conveyance or not. Also those timings of travel to scene, time on scene, travel to site, and clearance. So those we draw from distributions. The number of ambulances that can vary over time, and also the time in departments. Then in terms of output, so on one side we have the handover. That is something we do calibrate because we have a stylistic emergency department. So just to get it to the right levels. And then we also have the call queues and the time to allocate. And by definition, that also means that our whole response time is an output. And the other is the utilization. So what percent at each point in time is being used. So these are just some of the data sets that were used. We kindly had a lot of colleagues that helped us to obtain a lot of parameters we needed for the model. So that included ECDS on the interface to emergency departments, the National Ambulance Coordination Center data for supply, and then insights from the daily ambulance collection and some things from ambulance data set, and also a lot of software intelligence and existing modeling reports to inform both the model construction, calibration, and validation. So this is just some of the examples of inputs. So you have, say, the demand by category, 1, 2, 3, and 4. Then that can vary by time, but here it's fixed. Then we have the demand by care model. So here in treat here is 0 because we have set the focus to be face-to-face, although in theory you could change that in the model. And then also how that translates into ED acuity by category, because that's something we use to inform the prioritization at the point of handover. And on the right-hand side, we see what we draw the distributions from. So for each patient, if they have a certain category, what might be their time to travel to scene, time at scene, time to site, and time to clear for the next job. And this is some examples. So this is, 360 hours is 15 days. So you can see the walk-in demand in orange on the left-hand graph, and also the incident, so ambulance incident demand. So you can see the variation in terms of hours of the day and then each day. And on the right-hand side, you have what we say are the vehicles that you have available during those points in time. So this is the model we got to. So in some ways, what's on the right-hand side is actually similar to the other graph that was horizontally. So focusing on the branch on the middle, we have a certain amount of demand that has a certain category and care model. Those will then try to request an ambulance. So that's that top thing in blue. Then there'll be some time to mobilize, travel to scene, and time at scene. Then it branches, so it can be see and treat on the right, where you release an ambulance then, and that ends the job, or see and convey, where you travel to site, you request an emergency department resource, and two things actually happen in parallel. So the ambulance clears and is released, and the patient spends time in ED and eventually releases that. And there is some competitive walk-ins here on the right-hand side. So I'll just show some illustrative outputs of what you can get from the model. So on the left-hand side, so what we're showing some of the metrics you might recognize from the also handover publications. I think it's now in the ambulance SITREP, or you see SITREP on handover delays. So you have the one of delays 30 plus minutes and 60 plus minutes. So you can see it is varying over the days of the week, and you can also look at the total time lost for handover delays. As I said, this is something we calibrate for to a certain extent. But then a lot of it is like the model is, it still depends on the demand and other factors that you give the model based on actual information. And then on the right-hand side is what you actually obtain in terms of a response time mean per day of the simulation by category. So 1 at the top, 2, which is those 2/3 of calls that include, for instance, stroke, and then category 3. And you can see, so I guess first you see the time to respond increasing by those categories. You can also see maybe this kind of surge at day 8, 9, 10, which is also where you see surges there in delays to handover. Thank you. So perhaps more interestingly, so this is where we actually look at the relation between availability of vehicles and the category 2 response. So this type of curve behavior is typical what you see from queuing systems, but it's also what has been seen in some econometric relations for the various ambulance trusts. Now, the exact levels and where the inflection point is does vary, but what happens is there's a trade-off between those two. And then at high availability, actually, at some point, you don't improve much more the CAT2 response time because, for instance, it gets limited by time to travel. And then at some point of low availability, you can start getting a very broad range. Obviously, that might depend to the level of escalations you have in place, but the system becomes unstable in a lot of ways. So what you then can, for instance, do is look at what-if scenarios. So here I just put 2 as an example of increasing the number of on-duty vehicle hours, if you remember that graph, by X%. Or for instance, what if we moved a certain conveyance, in this case, the lower categories, to see and treat? What would that mean? So one way of just showing this is what it does to the curve. Some things move along the curve. There might be changes that actually substantially shift the curve itself. But in this case, if you increase 10% the hours, you see the availability increase and how category 2 response time changes. Also, if you were to decrease the conveyance by 40% for those, so this is about 1/5 of the incidents in the model, you also get to that kind of level. Perhaps interestingly, just you have other indicators, but for instance, obviously decreasing conveyance, what you also see is you have the handovers, 30 breaches decreasing, and the stylistic A&E utilization decreasing. In this case, we're not assuming that those will end up as walk-ins. The last thing, so just show, this is another example. So actually what we're doing is here, at some point after 7 days, just as we're decreasing the capacity, so abrupt decrease in capacity in our A&E. And then this bottom graph, sorry for it being pixelated, but it's basically the steps of the job cycle time. So this is the clock stop from ED. And here the points is indicating where there's breaches in category 2, and this in handovers. The top branch is the base scenario, the bottom is a disruption. And actually what we see is that there's a lot of more disruptions in this case. Okay, so up to this point here, everything's the same in the top and bottom branch because it's the 8th day. The actual days here are fictitious, it's not May. But what you'll start seeing around day 8 is just basically the consequence of that. I'll just move it forward. So yeah, what you can start seeing here in the bottom branch is that you start seeing a lot of cases going to category 2 response time delays and queues forming there. And you also see here an increase in breaches to handover as well. So this can be useful to just actually see what's happening in the system. This is on simulated data, but you could do similar with actual data more in terms of process mining. So yeah, just briefly, there's a lot of questions that could be answered with this type of model. I showed a couple other things. You could change the schedule, or what if there was, you could shave some time off of some bits of the job cycle time, maybe benchmark it to other trusts. You could do goal seek, which instead of is saying, what would it take if I could only change those two parameters to get to something, and accounting for dynamics. Yeah, we have an open repo that you can find there. The documentation is also linked from there. Just on two things on improvements, including more behavioral changes and those effects. And the second is it worth interfacing with an ED module, or better accounting for some econometric models that show how handover depends on downstream issues. And here's just, yeah, some of my contacts and some talks from colleagues. Thank you.
Thank you.